I actually just have a few more slides, and then most of it is Dr. Bruno. My focus at this point, and the slides aren't up again yet, but my focus at this point is to kick off the treatment portion of the program. And where I talked about primary MS pain, that's the focus of my talking about treatment, is in primary MS. Before even kicking off, I think the idea of this sort of pyramid or triangle that you see on the screen is very important, because it just goes back to what our mothers or our parents taught us, that an ounce of prevention, right, is worth a pound of cure. And so a very important point is the base of this triangle, or the base of this pyramid, is the biggest and most important part. We would like to prevent pain. And in MS, the way we would like to try and do that is preventing as many of those lesions in that somatosensory pathway that we talked about in the anatomy part. We want to prevent those lesions so that we're going to prevent that ephaptic transmission. We're going to prevent the pain matrix getting bigger and more entrenched so that it's hard to treat. And so Dr. Bruno reminded me, something that one of her mentors told her, and that is to try and get your personal message across. And so, sorry to welcome you back and start with something very heavy, but I find it a very difficult encounter in the office when I see someone early on with MS, young and quite healthy, the first attack, the second attack have maybe come and gone, and they feel well, and it's a very difficult conversation to have them start disease-modifying therapy. Now, I am not saying that absolutely everybody coming through the door needs to start today. I'm not saying that. But I'm saying to be open to that conversation and make the decision together to start disease-modifying therapy as early as possible in the course of relapsing remitting MS, so that we're at the base of this pyramid. Here we're talking about pain today, but as early as we can treat, the better we can be on the preventative side of things. And then moving up the triangle, we can't prevent it all, even with early disease-modifying therapy. And so the non-pharmacologic treatments, the biopsychosocial model is very important. I read a quote in preparing for this that pain, especially chronic pain, is a biopsychosocial experience. There's that word again. It's not just the pain, it's the things, the feelings, the meanings that go with it. It's the things in the person's environment that are so important. So the biopsychosocial experience. Dr. Bruno has already talked about a lot of things that can be modified, and in the treatment part of her section, she'll talk about other things that can be modified that don't have necessarily to do with a prescription pad. And then at the top of the pyramid, the top of the triangle, is the prescription pad. We have many different medications, and physicians being physicians, at least maybe I should speak for myself, neurologists as opposed to neuro-physiatrists, maybe take out the prescription pad more than we talk about how to adjust seating, because that's not the basis of our training. So I'll talk about medications that we do have to treat pain in just a moment. So we can divide up, there are similar slides to this for my area, primary MS pain, and Dr. Bruno's, and they just divide into the different classes of medications. So in the wheel, if we go around clockwise, there are antidepressants and anti-epileptic medications. There are topical medications. Coming around, there are the cannabinoids, anti-spasticity agents. Actually, those two things, the topicals, the cannabinoids, Dr. Bruno is going to talk about, and coming around there are the atypical narcotic medications. You notice that typical narcotic agents are not there. So we see a lot of people that are on opiates. We hear a lot about the opioid crisis, and I could go right back to that pyramid slide. We want to do everything we can to prevent having to get there, because that's a big problem. So a few words about the first of those, which are the antidepressants. What I'm most used to in my office are the group of these that are called tricyclic antidepressants, and the ones you might know are Avental, norepinephrine, or Elavil, the amitriptyline. I just said norepinephrine. Sorry, I blocked that. Yeah, nortriptyline. I use more nortriptyline than amitriptyline because they tend to have the same effect, but the nortriptyline has fewer side effects. One of the main side effects of both of them is that they make people drowsy. And so here, thinking of this interdisciplinary approach, and that multiple problems can be going on, and that there can be positive feedback loops, if I see someone that has chronic pain, neuropathic pain, and they're having trouble sleeping, maybe the side effect of drowsiness, we give the medication at bedtime, maybe it's not such a bad thing. So it can help their sleep architecture as well as helping their pain. If they're not having as much trouble with sleep, I tend to use the nortriptyline. We tend to start very low, like 10 milligrams. And I always have to describe with these medications that, yes, they are in the family of antidepressants, but I'm not saying you're depressed. That's not my focus, at least. There may be depression, but I'm not talking about using this antidepressant medication to treat depression. I'm talking about using it to treat pain. And there are better things, frankly, for depression nowadays, but when these were used for depression, they were used in the range of 100, 150 milligrams, whereas for pain, I start with just 10 milligrams. After a couple of weeks, I might increase it to 20 milligrams, and after a couple more, up to 30 milligrams. And I usually have them stop there until we can talk again. In some people, we push it higher, 50, 75 milligrams, still typically at bedtime because of that drowsiness problem. If people are drowsy the next morning, sort of a hangover effect, we'll try and give it earlier in the evening so it has more time to wear off overnight. Usually for these medications, giving a 6 to 8 week trial, and especially with at least 2 weeks at the higher dose, is a pretty fair trial to see if it will manage their pain before we adjust the dose, if we're able, or change to something else. At the higher doses, there are other side effects that people don't like weight gain, and they have a lot of anticholinergic side effects. So that's like dry mouth, or for men especially, they may have trouble initiating peeing, if they have prostate problems especially. Women can have that problem too at higher doses. The SSRIs are newer antidepressant medications. Those are the serotonin reuptake inhibitors, and that family doesn't tend to be used very much in chronic pain because it doesn't prove to be as useful. But the cousins, if you want, not just serotonin, but serotonin and norepinephrine reuptake inhibitors, the SNRIs like duloxetine, those have been very helpful for pain. They have, as I said, effect on serotonin and norepinephrine both. The usual dose there is 60 milligrams to start, and then increasing to 120 milligrams is possible, though the studies didn't actually show that it was more effective at 120 milligrams than 60 milligrams. The individual doses are not as important in this forum, because whenever we're talking like this, we're always talking, remember those fall asleep epidemiology slides? We're always talking about the population of people with multiple sclerosis, a large study. You saw Dr. Bruno quote some studies that were 400, 500 people. Whereas the person in front of you in the office, you in the audience, you're 100% of the people that we're treating at that point in time. And so where the studies don't show that a higher dose of duloxetine, for example, would be helpful, in the individual person, we don't know until we try. So we look for some flexibility there. Another sort of tangent from this slide is that the studies, we try and do things in medicine more and more on what's called an evidence-based basis. So we have studies that show in a population, not in you, the individual, but in a population, what's going to be more effective, what's going to be less effective. And we don't, unfortunately, have many studies talking about treating pain in MS. So we have to extrapolate. We have to use the studies that are available, and just by sheer numbers, something as common as diabetes that can damage peripheral nerves and cause neuropathic pain on a peripheral nerve basis as a start, but then it follows that pathway we looked at. It's got that bigger matrix in the brain. There's learning involved, and you've got chronic pain. Those are such a large number of people. I saw an estimate of about 10 million cases of painful diabetic neuropathy in the United States. 10 million people. So that's why when you look at the American TV channels, you see those ads for treating your painful diabetic neuropathy. That's where the studies are. That's where the populations are. That's where the pharma money is to investigate and prove that those medications are helpful. And then we sort of piggyback on that, saying it wasn't studied in MS, but we're going to try and see if it works just as well as in the other populations. So I talked about the antidepressants briefly. Another family of medications that we use are the anticonvulsants or anti-epileptic medications. And here, if I right away talk about that American TV ad about diabetic neuropathy, here's where you find pregabalin, Lyrica, as an example. Or you might find Topamax, topiramate mentioned as well. So those are examples of medications that are available for controlling epilepsy, but they can also be helpful for controlling chronic pain. And you see some others there as well, gabapentin or Neurontin, and lamotrigine or Lamictal. We can even use some of the older ones like valproic acid, which is Epival, but we don't as often use those other ones. Or at the bottom is listed levetiracetam, which some people might recognize as Keppra. Valium is there as well. So I don't have as much experience with those, to be honest, but I fairly frequently will use gabapentin. It starts with a very low dose and can build up to quite a high dose over a long time. The Lyrica or pregabalin usually start at 75 milligrams, and we can double that over time. And some people even take a higher dose than that. Again, it's an individual approach. Most people have more side effects at higher doses. The anti-epileptics, I think, are an interesting group just to think back to what we talked about the wires and the crosstalk called ephaptic transmission. And I try and explain that to people in the office. I want to be honest, mention epilepsy. And just like I'm not saying your antidepressant medication is for depression in this case, it's for pain. I don't think you have epilepsy either, but I'm talking about epilepsy medication. I want to reinforce that the medication doesn't know why we're giving it. And so an epilepsy medication that someone after several months decides they don't like and they stop could trigger a seizure. So that's a very important side effect to talk about. So in epilepsy, you want to sort of quiet down that abnormal electrical activity in the brain that's causing a seizure. And that abnormal electrical activity is the same thing we talked about with those wires and the crosstalk of ephaptic transmissions. That's kind of how they work. They work at a microscopic level by adjusting what are called channels. In our nerve fibers, we have channels that let in sodium and push out potassium, or let in calcium, all these different channels. And this group of medication are also known as membrane stabilizers because they affect these sodium, potassium, or calcium pumps, and they change the amount of those ions that are in the nerve, in the fluid of the nerve. And it's those chemicals that give the electrical impulses, the shock that we talk about that goes through a nerve. And so if you can control that, you can make the nerves less excitable. And that's what those medications try to do in epilepsy, or in this case, in pain. So I think those are the main things about those medications. Atypical narcotics are a family that I don't frankly have as much experience with. In talking about this, sort of studying up before we came today, it's nice that we live in the same place. We're able to prepare some things together. Dr. Bruno has more experience with these atypical narcotics than I do. But I certainly am able to say a few words about them. So the main one that people might know would be tramadol or Tramacet. And this is a medication that is working like a narcotic medication, but it's not exactly a narcotic medication, which is a good thing. The atypical part is a good thing. It works on different receptors. It works on what are called mu receptors in the brain, and also has some effect with the same norepinephrine or serotonin that we were talking about with the antidepressant medications. I'm not sure if anyone's heard here of serotonin syndrome. You can have a problem. I talk about it quite a bit in the office when I talk about migraine medication, because some of those act on serotonin, and many of our antidepressants act on serotonin. And when you're on two medications that act on the same chemical, there's the risk that that chemical can go too high or too low in the brain. And in this case, we need to be careful if someone was on an SSRI or SNRI and we added tramadol or Tramacet, that they could have this serotonin syndrome, which affects the temporal lobe, so it affects memory. It can give a fever. It can make someone's level of consciousness go low. It can be a real emergency. So that's something to be aware of with this medication. These are strong medications. Oftentimes these medications are used it's still chronic pain, the neuropathic pain, but it's in sort of more of an exacerbation. If we say acute on chronic, it's chronic, but it's gotten worse lately. And we're trying to implement one of the other strategies that I talked about, an antidepressant or an anticonvulsant, but you might have seen they take some time to increase the dose. So we try and use these to temporize a little bit. Methadone is not something that I think either one of us have firsthand experience with, because you have to be in a specialized clinic, a licensed clinic, to prescribe it. And that's often in the setting, in my experience, of someone that has unfortunately got on bigger and bigger doses of opiates over the years, and now, hopefully, we're trying to reduce that, replace it with one of the atypical agents, which have less deleterious side effects. So those, I think, are the main things I wanted to say, and we'll move on to the cannabinoids that Dr. Bruno is going to talk about.
Just before we move on to the cannabinoids and cannabis, I just want to say just a few words about those topicals, because the topical agents would be combinations of the medications Dr. Robinson already talked about, put together in a standard cream base. So there's not a lot of literature out there in the adult population, not a lot of literature out there in the MS pain population. There's some, but not a lot, looking at the use of topical compounds in the context of chronic pain. But they are used, and in certain cases are highly, highly effective. They've been used in complex regional pain syndrome, especially in pediatric patients. They've been used in spinal cord injury pain, which spinal cord injury pain, neuropathic pain, is really often very hard to treat. And what these contain would be a smidgen of gabapentin, a smidgen of amitriptyline, maybe some lidocaine. You've heard of lidocaine and as an anesthetic agent for, putting your gum to sleep before a dental procedure, and something called ketamine. Ketamine is a dissociative anesthetic. Ketamine is actually used to put people under in procedural sedation or general anesthesia. And so you can take all of those compounds, you can slop them together in a cream, and then you can apply that cream to the body part that's painful. And now we circle back to that original cartoon diagram that Dr. Robinson talked about, where you have the sensory input coming from that body part way in the distal area, say the toe or the leg, and it's feeding that information up towards the brain. So the way we think these topical agents work is that they actually are absorbed by the sensory nerve fibers and are taken up by those sensory nerve fibers and transmitted or modulate the transmission of signal through the peripheral and then the central nervous system. So, you know, it's worth a try if you're very concerned about systemic side effects. So some of the side effects Dr. Robinson talked about, maybe sedation or maybe urinary retention or maybe dry mouth or anything else. And you have a very localized area that burns or has pins and needles or has some kind of really awful pain problem, but it's a very well demarcated zone. It may be worthwhile trying some of these topical agents. Now, not all physicians have familiarity with this, so you may need to be referred to a pain specialist or a neurologist or a neuro-physiatrist, physiatrist, but there are people out there that know how to use these pain compounds, and as much as possible when I'm generating my reports and I'm going to prescribe something like this, I kind of go through what's involved, and then I have the primary care physician, the family doctor, continue it. So, moving forward, I'm going to talk about cannabis and cannabinoids, and I want to say two really important things. Number one, just because something is natural doesn't mean it's the right thing for you. Now, on the corollary of that is, it could be, but just keep that in mind. You know, a lot of people come into my clinic and say, doctor, I don't want that drug that you're prescribing. I don't want the Lyrica or pregabalin. I don't want gabapentin, but I want to just stay with my vaporized cannabis. It's working well for me. I'm like, okay, no problem. But they say it's because it's natural. And I counter that by saying, well, actually tobacco is just as natural. And cocaine is actually just as natural. There are a lot of other things that are just as natural that you wouldn't necessarily want to use in that particular instance as your first choice. It could actually be used lower down, and there's definitely a role for cannabis and cannabinoids in the treatment of both neuropathic pain as well as spasticity, but they are third or fourth line in terms of use, and they are third and fourth line for a couple of reasons. And this goes back to the second point I want to make. You get nothing without a trade-off, and that's with whatever pharmacologic agent you're using. The trade-off could be a side effect. The trade-off could be cost. The trade-off could be a combination of those things, time involved, energy, how you use it, but there's always a trade-off. And when physicians, clinicians, look at the trade-offs versus the benefits of the agent, we make a little decision of what outweighs the other in any given situation. So we always are aiming to say what is of the highest benefit with the lowest risk. And so your first line agent is going to have the biggest bang for its buck. It's going to have the highest benefit, the lowest risk, and so on and so forth. And so when we come to cannabis and cannabinoids, the research is at the stage where there are a lot of things making it just slightly up in one circumstance or slightly up in the other direction the other. And one of the things I caution my MS patients about in regards to cannabis use would be, if you're using a THC-based compound, the potential for cognitive side effects, the potential for mood-related exacerbations, and this is hard to predict, it's very difficult to know who might be affected by this, but there can be some significant psychiatric complications with cannabis usage. And again, it's a proportion, it's not everybody. One of the things that I try to help my patients maximize at any point in their disease trajectory is cognition. So for any patient that comes through my office, I want to focus on that to try to keep that as robust as is possible. And there are a lot of different ways to do that. it's outside the scope of this talk to go into it, but one of the strategies is to reduce the amount of cognitive hits that are coming externally onto that person. And in regards to cannabis, there can be, especially with THC products, a cognitive hit in terms of processing speed, in terms of motivation, in terms of memory. So that's all very important to understand. It's also very important to understand that overall, as a class of medication, cannabis would still be classified as a depressant. So I have a lot of persons that come to me and the cannabis is being used for sleep induction and it's used for anxiety. I don't always make changes, and sometimes we're working with that approach, not a problem, but it's important to educate and be aware in the context of cannabis, especially with THC, but not exclusively, and I'll talk about cannabidiol in a second. You can get tremendous amounts of rebound anxiety. So where the person is predisposed to anxiety, either constitutionally or because MS in and of itself may alter the areas of the brain that stabilize mood and control mood in the same way they can alter those pathways from the pain matrix. You can get anxiety because of your MS lesions. And so, of course, when the cannabis is on board, especially THC, there can be a sense of calm. But that's when the cannabis is on board. When the cannabis is not on board, then there can be a little bit of an exaggeration from where the baseline would be. So then it becomes a bit of a, always trying to catch the tail and going around in circles. So again, for some of my patients where we've tried first line, we've tried second line, and we're starting to get into the third line, there's definite roles for these medications. And when we're talking about cannabinoids, they come in two varieties. There's not a lot on the market right now. Probably in the future there will be more. But you have pure THC-based products, which have been used for many decades, not just in MS-related contexts, but to help with cancer pain, to help with cancer cachexia, that's the wasting that often accompanies cancer, which makes a person not want to eat, or if they're eating and taking in the calories, they can't keep those calories. So sometimes it's used for that. Sometimes it's used to calm nausea related to chemotherapy use. And then there are products, there's only one right now in the Canadian market that is a 1-to-1 ratio of THC and cannabidiol, and that is called Sativex. And the cannabidiol is there because it's got no psychoactive properties. There's no euphoria associated with cannabidiol, and there's some thought that the pro-seizure or anti-seizure components of the THC are somewhat balanced by the cannabidiol. So it's there as an adjunct to the pain, it's adjunctive to the spasticity treatment, but it's supposed to counteract the effects of the THC. That is produced in an oral buccal spray, and it tastes, I've been told, not pleasantly, but it goes under the tongue or at the cheek. And sometimes it's very helpful for persons who are traveling, who are relying on their cannabis products, whether they take it in oil form or they vaporize or it's used by combustion. Sometimes it's hard to take that across borders depending on where you're traveling. And so having a period of time where, you know, I'm happy to provide a prescription in that context to give a person some Sativex so that there's no withdrawal and they're not without coverage, but they can safely go to the US or they can go to wherever they're traveling. So something to talk to your physicians about if that happens to be something of interest to you personally. So there is a very high prevalence of cannabis use in the MS population, and I had a kind patient bring me a big textbook like this about everything you ever wanted to know about cannabis, so I enjoyed that read. And even way back when I trained in Nova Scotia, it was something that was really like a new thing in terms of sort of therapeutic strategy, and it was all a buzz. And I remember going to a lot of talks as a resident for free food about cannabinoids and cannabis. But one of the things I want to caution on is combustion of cannabis. I really try to steer people away from combustion, and by combustion I mean burning the leaves, because the byproducts of the combustion are possibly more toxic than burning tobacco leaves, and many of my patients are used to cutting the joints with tobacco, and tobacco combusted products and cannabis combusted products, they actually work synergistically and increase dramatically the risk of irritation of the lung linings and the risk for lung cancer. Now, I'll say another thing about combustion and MS. We know now that smoking is a risk factor for MS, and it's a risk factor for sort of severity of relapses. So the putative method, the thought of method to explain that would be that taking in the inhalational smoke activates the inflammatory system in the body. It's pro-inflammatory. It's seen as an irritant. It's seen as something foreign, and the body wants to deal with it. Well, when you have inflammation in one part of your body, it can have sort of domino effects to inflammation in other parts of the body. And we still think of MS, even at the progressive stage of things, as having an inflammatory component to it. So you want to keep overall inflammation in your body down. So if you have to use cannabis as a strategy for pain or spasticity management, either alone or as an adjunct, you want to choose ingestibles or vaporized and avoid combustion at all costs. I'm so used to touching the computer. So the take-home point, which summarizes the whole component of the treatment strategies for primary pain, would be that only a select group of medications is actually truly helpful to counteract that. And so if you have burning, shooting, stabbing, pins and needles, or electric shock type pain, it's really what was on that wheel that has been shown to be effective. And just to reiterate what Dr. Robinson said, morphine is not on that wheel. Demerol is not on that wheel. Fentanyl is not on that wheel. And there has been deemed really outside of very select cases, because in medicine you never want to say never, but outside of very, very select cases, there is not an overall general role for typical narcotics in the treatment of primary neuropathic pain or chronic pain in general. Medications are just one piece of the puzzle, and we don't want any of you to forget that it's just one piece of the puzzle. And in many cases, what these medications or the whole person strategy allows us to do in MS primary pain or chronic pain of any cause is to lessen the pain burden, but not necessarily eliminate it. So whereas everybody, if you take a pain rating scale that goes from 0, no pain at all, 10 out of 10 pain, the most severe pain you could even imagine, to the point that you want to actually end your life because the pain is that bad, and I have had patients get to that level or beyond. My goal as a treating physician is to get that person to a 2 or a 3 out of 10. That's a success on my end. Now, if we manage to get to a 1 or we manage to get to a 0, hooray, we will celebrate, and it has happened. But really the target is 2 or 3 so that the quality of life is maintained, the coping with the pain is adequate, and ultimately, you can go about doing what you love to do, that your functional independence is at the highest level it possibly can be. So having appropriate expectations of treatment is very important in that whole understanding of meaning of the pain. Because if you have the appropriate expectation, that actually reinforces the effectiveness of the treatment strategy that you are using. There's a really, really neat study that, this is just a very mild digression, but a very neat study about looking at placebo effect. And placebo effect, we don't call it placebo effect anymore, we call it expectation. So there's positive expectation about how some treatment will work, and there can be negative expectation. And there have been randomized trials where a group of persons is put into one of 4 categories. A group of people that are about to get the product, but they have been told that the product won't work. group of people that are going to get the product, and they've been told that the product's going to work really well. And those two groups actually have the pain. Okay? And then there are the other groups, they have the pain as well, but they're being given placebo. They've been told, so it's just a sugar pill, not a real active ingredient. They've been told placebo is going to work really well. They don't know it's a placebo. This product, this pill is going to work really well. And the other group told that it's not going to work really well. So then you can itemize, okay, who does the best? It's not necessarily intuitive. So people who were told that they would do really well and actually got the effective drug obviously do the best. They do the best. But second best, it's a very neck and neck with whether they actually got the drug or they got the placebo, but that it was going to be, they thought that it was going to work super well. It's actually that group. It's the placebo that outruns the real drug when people think the real drug's not going to be helpful. And then it's obviously the real drug with negative expectations. And lastly, it's no drug at all with negative expectations. And I think that's a really elegant reminder that how we think of something has a very big impact on our perception of reality. So in secondary MS pain, it's analogous to our strategies in a way of dealing with primary pain. At the foundation of that pyramid or triangle, we want to address whatever is the predisposing impairment. So if the issue is back pain and the problem is really that the pattern of walking is at the root cause, well, let's get that pattern of walking normalized, or let's get it to be the best it possibly can be. So let's address that impairment. And then we can look at specific non-pharmacologic strategies that affect that pain if we can't eliminate the problem altogether. And then, of course, we can go to drugs. And here, the wheel looks a little bit different because only one piece of that pie would be drugs. The other pieces are adjunctive, but maybe more important than the drugs. And that would be all kinds of lifestyle modifications, and I'm going to go into some that I think are really helpful. And also going to the appropriate allied health specialist. That could be a physiotherapist, a social worker, an occupational therapist to deal with what that particular problem is all about. And then, of course, using technology. And technology can come in many forms. It can come in assistive devices that are really simple tools, all the way to the most elegant sort of communication strategies and computerized mechanisms, and various devices like braces, special mattresses, aids in the home, sort of bars installed, this, that, and the other. So one of the strategies would be to fix walking problems if a person is still walking, and this would reduce the abnormal forces on the joints, the soft tissue structures, which are those tendons and ligaments and cartilage structures, and ultimately reduce the risk for falls so that you don't get that secondary tissue trauma and wind up the primary pain. Because one of the things that, if it wasn't clear before from that House of Cards demonstration, is that any pain, additional pain generator that a person gets, even an ingrown toenail, on the backdrop of that primary MS pain, is going to easily wind up that primary MS pain because of the phenomenon of central sensitization. So you want the appropriate management of spasticity or ataxia, weakness. You want to have a really good stretching and strengthening program. You want to correct maybe leg length discrepancies or abnormal postures and attitudes of individual joints. You want to, have the appropriate footwear. I won't belabor to the point. I think you can see where I'm going with that. Seating again, really critical. You want to make sure you can maintain your core strength as much as possible. You want to help with truncal stability if it's lacking. You want to maybe even for a few hours and not more than 4 a day, have a corset or an abdominal binder. Sometimes that is enough to give some support to the structures that can hurt, but can also increase the mechanical advantage of the diaphragm, which is responsible as the main muscle to giving us our good, deep inhalation, exhalation, and we all need to breathe. Breathing is very important in terms of oxygenating your tissues and your brain, maintaining relaxation, and having the least pain severity score as you can. And then, of course, adjusting your body positioning within the chair, having a good chair, having it measured appropriately, and then also kind of tweaking individual body parts. So, making sure that the elbow is not resting on a very hard surface, making sure that the foot and ankles are at 90 degrees orientation. Maybe that needs a brace, or the knees are at 90, because that will lessen spasticity. We want to, most importantly in all of this, prevent secondary complications of immobility. And that would be to make sure that the joints aren't stiffening up, that you're not getting skin breakdown, that you're not having problems with your elimination function, so going to the bathroom, that you're not retaining your urine and then predisposing yourselves to urinary tract infections or bladder stones or changes to the bladder lining, which can sometimes even escalate to, if not precancerous, frankly cancerous stages. And you want to look at bone health. And then, of course, I've talked a lot about MSK, or musculoskeletal related pain, but we have a ton of organs in our abdomen and chest that can also contribute to pain. So, are you brewing an appendicitis? Do you have gallstones? Are you having problems with irritable bowel syndrome? Like, there's lots of other things that can cause problems in and of themselves, and then again, wind up that central pain. I'm going to spend some bit of time on sleep because I want to hammer home that there is a very strong relationship between impaired sleep and pain. And this is in a bidirectional sort of way, whereby if a person is deprived of sleep, like I talked about in that experiment that no one wants to do for chronic widespread pain, the body's ability to gate or say, oh no, that's not a problem, ignore that ability to gate really goes down. And so any little thing is actually perceived as problematic. That's one mechanism. And then, of course, as soon as the pain is escalated, then it's hard to get comfortable at night, and it's hard to actually fall asleep and stay asleep, so it's a vicious cycle. 50 to 80% of persons suffering from chronic pain have ongoing sleep disturbances, and this really struck me as profound. Disturbances in sleep better predict pain exacerbations, so worsening of pain, and occurrences of pain predict interrupted sleep. So it's more likely that you're going to suffer pain if you don't sleep well than you don't sleep well just because you have pain. And that I found very profound. So it says, have you done all you can to get your sleep on track? Maybe you need a formal sleep study. Maybe you have to take it to that level and sort of advocate for yourself for that. And the mechanisms underlying the relationship between sleep and pain are still not completely understood. There is that overlap of neurotransmitter use, especially maybe dopaminergic and the endogenous opioid. You have to think that for any drug that is out there, there's a part of the body that it attaches to or works on. And usually when we're dealing about drugs, there are a whole bunch of internal structures, chemicals, proteins, other substances that actually work on those receptors as well. You've probably heard of a high from extreme exercise. Well, that's recruiting this endogenous opioid system. So chemicals that are like morphine that our own body produces and dampen down pain, induce a sense of relaxation and of a sense of well-being. Improving sleep, then, should improve pain, and strategies for improving sleep are not just limited to going for a formal sleep study. It's all looking at sleep hygiene. I talk to my patients a lot about sleep hygiene when they're not sleeping well. I'm trying to get them on track with a set bedtime and a set wake-up time, because our body likes that kind of a routine. It likes to get entrained and predict. The bedroom should be used for sleep and for sex only. You should not be watching your TV or having blue light from a computer come and bombard you, if at all possible. Now, many of us have TVs in our bedrooms. Okay, well, maybe we need to shut them off by a particular time. Or maybe if we have a computer instead of a television, maybe we need to switch to a yellow light-based screen for the time period before we're about to think about going to bed. In fact, I usually counsel people to shut off devices, be it a smartphone, a computer, or a TV, 1 hour prior to actually trying to fall asleep. It allows the body's circadian rhythms and melatonin secretion to kind of normalize. And, limiting stimulants in the latter part of the day. That could be simply, timing when you're going to have a cup of coffee, and then maybe taking decaf after that, or teas that are sort of sleepy time teas instead of teas with theophylline. Or, making sure that you're not up every moment for the washroom, because you can actually address your bladder systems comfortably and get a better night's sleep. And again, the details of that are beyond the scope of this talk, but it's like looking at all the different ways to try to get good rest. I don't have it on this slide, but in the context of low mood, sleep can be deranged for that reason alone. So again, treating comorbid mood disorders, especially depression, would be really important. Research in diet is ongoing, and it's hard to recommend any one particular diet at this point in time. Diets that are very low in carbs have been researched a little bit in terms of pain relieving properties. So what is called a ketogenic diet, it's usually a high fat type, low protein, low carb type diet. It's been helpful in some seizure disorders. And looking at the mechanism of chronic pain or primary MS pain and seizures, you see that we treat them with anti-epileptics. So the thought has been, if a specific diet helps with seizure, then maybe it will help with pain, and there's some minimal evidence for that. Interesting to note that persons with chronic widespread pain, of which many MS patients complain, have higher rates of obesity, cancer, cardiovascular disease, and there may be, a whole complex interplay of reasons for that, some of which has to do with mobility and not being able to expend energy the same way, some of it having to do with sleep. We know that if we're not sleeping well, our stress hormones are changed. And when our stress hormones are changed, we put on weight more easily, and especially abdominal weight. So there are a lot of reasons to kind of explain that phenomenon. But the take-home point would be is, if this happens to be you, you might want to pay more attention to caloric control, and wherever possible, make the healthiest dietary choices. So mood, I alluded to in talking about sleep, and we alluded to before in terms of the pain matrix and where it is in the brain, and where it overlaps with the control of the mood state. There is a strong relationship between the two, and it is bidirectional, and it's very complex. But one of the most interesting things that I have come upon in terms of research work is that positive affect, so actually those feelings of gratitude, that optimism, that being able to enjoy or perceive positive emotions and sensations is actually perhaps more important than just not having negative affect. Negative affect being, thinking about the negative, feeling the negative, tending towards the negative. And there are a lot of strategies to help a person get out of those negative distortions or negative thoughts. but efforts should be expended in both domains, trying to decrease negative thoughts, negative feelings, and actually promote the positive, actively promote the positive. And it's been linked with a lot of health benefits, not just in terms of pain, but also in sort of the inflammatory state of the person. And then optimism, which overlaps with positive affect, has also been linked with better pain coping and lower pain sensitivity, and there may be ways to actually improve a person's optimism. There are cognitive behavioral strategies that help deal with positive and negative affect, and there may be group programs to participate in. Maybe there are support groups, maybe one-to-one psychology would be relevant. In any interdisciplinary pain program, a large attention is focused on mood state. And in interdisciplinary pain clinics, there is either a psychologist or a psychiatrist or both as part of the treating team. Of note, I'll reference quickly one study where they looked at patients with knee pain, and this is not strictly MS related, I have to say. This is where we extrapolate from other populations, but a group of patients with knee pain with high positive affect walked more than those without the positive affect with the same amount of pain. So they took two groups, persons with knee pain, and they performed psychological batteries, figured out who had the positive, who had the negative, and the amount of activity was really more predicated not so much on the pain, but it was predicated on their attitude. So persons with positive affect tended to push through the pain or not perceive it as limiting as those with the negative. And ways to improve the affect could be noticing and capitalizing on positive events. So just willing yourself to, I guess, be in the moment, be aware, and be open to whatever positive interactions you have with others, or the enjoyment of nature, or whatever is the positive in that moment. Developing gratitude. There's a lot of research coming out of Harvard about how important gratitude is. Cultivating mindfulness awareness, understanding your body in the moment, not just spending your time thinking about things past or worrying about things future. Highlighting your own personal strengths, getting to know yourself and being able to do positive affirmations, Yes, as you go through a chronic illness, you may have a change in how you perceive yourself. Some of those changes may not always be positive, and maybe you have to go and spend some time looking for the positive and reminding yourself about your positive strengths and your resilience. And then developing attainable goals, having appropriate expectation, and then this one is my favorite, engaging in acts of kindness. So that has actually been shown to improve a person's mood. There are resources that can be gotten through online purchasing, so through Amazon, through local area bookstores that are workbooks that have been around for a very long time and in multiple editions, where you can actually go through case studies, see what other persons are experiencing, and then reflect on your own experiences and kind of go through and dissect how you're feeling about any particular issue and move towards better coping in that regard. And then one of the things that I assign to many of my patients, or I challenge them to do as a little bit of homework, is to just take 5 things that they want to list every single day that they could be grateful for. And it can start from the macro level, and then as they get into it, go to the micro level. And that act of listing those things down, even over a 3-week period of time, has been shown to improve sleep, reduce stress, improve mood, and reduce pain in as little as 3 weeks. It costs nothing. For persons who are able to still write using their dominant hand, there is some extra added benefit in actually physically writing that out, because there is a connection between our dominant hand and our brain in a way that it interferes or modulates mood a little bit better than if we don't do that. But if you can't use your dominant side, you can dictate this. You could type it. You could think about it. As long as you're actually engaged in reflecting on what you're grateful for, that is enough. I could go on all day on exercise and physical activity, but I think I'm going to need another drink of water. Exercise is a talk, a 3-hour talk, all of its own. It could be a 6-hour talk. The take-home point, thank you. The take-home point from exercise is that there are a number of very powerful biologic mechanisms whereby exercise is helpful, not just in regards to directly addressing those pain pathways, but in addressing the secondary issues that feed into those pain pathways. So you have modulation of your immune system. So maybe you're actually quelling your disease activity by being active in exercise, especially aerobic exercise. Maybe you're perfusing, bringing blood to your pain matrix structures, so your brain, your spinal cord, your nerves, by doing exercise, and by bringing the blood flow to those areas, you're providing nutrients and oxygenation, and you're taking away negative byproducts of metabolism. Then you've got the benefits of just increased endurance, increased strength. You could have a reduction in your adiposity, which is your amount of body fat, and so your body composition can change. You can change parts of your metabolism at the muscle level and at the general level, so that you're cutting down your risk for secondary complications of immobility, which means that maybe you're preventing yourself from getting a diabetes, or you're preventing yourself from getting cardiovascular disease. And it's really important to know that just because a person suffers from MS or has MS, that they are free from getting other health problems. Other health problems also happen. And so what you can do to prevent those other health problems will have a positive impact on that total person approach to staying at one's best with MS. There are guidelines for exercise in the MS population, and very briefly speaking, it's at least 30 minutes of moderate intensity aerobic activity 2 times per week, which can be chunked in 10-minute segments, and strength training for the largest muscles, at least twice per week, and again, usually 8 to 10 repetitions, 3 sets for each major muscle group. And the exercise is not in any way going to promote disease progression. In fact, the converse. It's not going to promote relapses, actually the converse. And it's certainly not going to worsen fatigue. Exercise is a primary treatment strategy for fatigue management, and it's a bit of a leap when you're really feeling tired to want to get yourself to exercise. That is a barrier. The feeling of tiredness can be a barrier, but once you get over that hump and you institute a program, you'll see that your overall fatigue level goes down. And you should always think about exercising in a cool environment, so that something called Uthoff's phenomenon, which is a slowing down of the signaling in MS-affected neural networks, doesn't happen. There's lots of ways to stay cool. I've shown a picture of cooling vests that can be worn, in hot, humid weather or while exercising. But just having a fan or taking some ice water in between bouts of exercise can be helpful. Sometimes even using just a spray bottle spritzer with cool ice water is also helpful. And then to remember not to go to exhaustion. And these, doing these guidelines or achieving the guidelines, which are minimum targets actually, can improve fitness parameters, we know that, may reduce fatigue and improve quality of life. And although there's not specific randomized controlled trials to show the benefits, the treating physician community, at least in PM&R, physical medicine rehabilitation, would be very happy to vouch for exercise as a spasticity treatment, a treatment for neuropathic pain, improvement in sleep restoration, correction of depression, improving cognition. We know that exercise actually is one of the #1 strategies to cutting down Alzheimer's type dementia risk. And then also improving bowel bladder function, maintaining healthy bones, and again, reducing problems that come with inactivity, such as diabetes, obesity, heart disease. And you can get really good information at the MS Society webpage or at the webpage from the Canadian Society of Exercise Physiologists. And in terms of CSEP, you just have to search multiple sclerosis on their main page, click on physical activity guidelines for special populations, and then there's a whole bunch of resources there. And there are a ton of resources through the MS Society, as most of you will already know. And finally, we are nearing the end of the marathon talk here. Energy conservation and pacing. It has one of the last slides, but it doesn't mean that it's just a forgotten topic. Don't want you to burn the candle at both ends. I'm going to repeat what a mentor and colleague of mine says all the time. Says it all the time to me. Work smarter, not harder, and avoid that weekend warrior type approach. Everything that you do should be with a mind to do it safely and for the long haul, which means starting low and ramping up very slowly. And I've put on the web address where I got this slide, and it's from a rehab center, and it goes through the principles of energy conservation as having 6 Ps, and they're very self-explanatory. You know, you want to look at ergonomics. That would be positioning. Try not to put abnormal stresses on your body during the day. You want to practice to become more efficient at things that you do. You want to plan out your day, plan out your week, plan out your month, so that you can capitalize on achieving your own priorities. And then, of course, when you're doing that, to pace yourself. What does pacing mean? Well, you're going to do a little bit now and then rest. Going to do a little bit now and then rest, instead of trying to complete it in all one fell swoop. And then, of course, the other P, which piggybacks onto the slides that I talked about just a moment ago, is that component of physical fitness, to stay fit, conditioned, and as strong as you can be. Now, a little caveat. I know many of you are thinking, well, I'm non-ambulatory. I don't walk anymore, so how could I stay fit? There are ways to adapt exercise for almost anyone who still retains some limb function. I have to admit, when persons lose all 4 limbs of function, it's very difficult to meet exercise targets, very difficult. Although there are still some breathing exercises that are very important to still do. But granted, if you have some upper limb function, you're still able to get your cardiovascular fitness up, maybe using something called an arm cycle ergometer, or working with a physiotherapist, kinesiologist, physio assistant, maybe even a personal support worker, to try to get in assisted exercises throughout the day. I'm going to stop talking and take some water now and hand this over to Dr. Robinson.
It's going to be frankly embarrassing how long I'm going to be standing here now. I have 2 slides. Dr. Bruno just left it to me to summarize, and it's awful. I don't want to get mushy, but it is a room where your parents celebrated their wedding. I thought that was fantastic. I'm very grateful for you and all your work on putting this together. So we've talked about how common pain is in multiple sclerosis. We said, just to remember a rough number, that it's affecting at least half of the people that have multiple sclerosis. And we've talked about how to classify it according to where the lesion or abnormality in the nervous system might be. We've talked about neuropathic pain versus non-neuropathic, which would be the noxious stimulus type pain. And we've talked about how it's related to the multiple sclerosis, whether it's one of the primary problems like optic neuritis or trigeminal neuralgia, etc., versus a secondary thing, the low back pain of improper seating or altered gait, or just I'll say just, but we have to remember comorbidities as well. And the point that Dr. Bruno made about comorbid things still winding up those pain generators to make that matrix bigger is very important. We talked about management strategies, and it's just incredibly important, and in Dr. Bruno's clinic, they're really well set up to do this in an interdisciplinary fashion, and I think it's a model for other clinics to follow. I spend some time at St. Mike's, and there is an interdisciplinary clinic there, which is improving. I spend most of my time as a community neurologist at Markham Stouffville, as you heard, and I have an office and a secretary. I don't have a team, and it would be very important to develop a team approach, to discuss that with your primary practitioner as to what other practitioners can be brought in to help, that we really have to think about it on multiple levels. So that could be treating comorbidities like anxiety or depression, and that could be treating sleep, that could be attention to the diet and exercise, as you've heard about. I think it's very important, the point about realistic goals, and I'm going to change just slightly the business of the 0 to 10 pain scale, or the so-called 11-point pain scale, that I agree, we want to get it down as low as we can, but it has been shown that even a 30% reduction, so now that could be 10 down to 7, let's say 6 or 7, not all the way to 1 or 2 where we want to be, even that 30% reduction is a meaningful reduction, as in quality of life, as in day-to-day function. So I know that everybody in this room wants the goal to be 0 pain, but we do have to be realistic about what we can do. And I think there's just one more, which is was mentioned in the objectives by Dr. Bruno, the call to action. So whether you're currently suffering from pain or just to lessen the chance of pain being part of medical problems, we would really like it. It has the most impact to actually take the action step of choosing just one to start, one of these things, visiting one of the websites that were mentioned. You'll be able to access this and the materials afterwards if you're not able to take a note. Start listing some things you're grateful for. I only have 4 left to go today. Taking steps to improve your sleep hygiene. Talking to your care providers, I guess I've just mentioned that, about the strategies that you can bring from things that you have learned in how to effectively manage pain and all aspects of your care. And finally, and I hope we still have some time to ask us a question. Thanks very much.
So I am realizing that some of you may have to pick up a ride at 4:30ish or afterwards, so we'll go through this quickly. I just want to say it was very evident in the presentations of both Dr. Bruno and Robinson that they do consider and treat 100% of the person that is in their room. So we appreciate that in their office. Thank you very much. So, thank you. So, any questions? And I'm going to do the same process. Where's my little mic people? Okay, we'll start with this end and we'll work our way across. So Jennifer, there's one right there in front of you.
So I'm just, sorry, you're supposed to hold it. Yeah. So I'm just wondering, nobody's mentioned low-dose naltrexone, LDN. It's widely used in Europe.
We can, is this working? Yeah. We can both take a stab at that. I have absolutely no objection to prescribing LDN, and I do when it's requested of me. I feel that it's a very safe product, and so I have no qualms about it. If a person feels that it could be of value to them, that's good enough for me, because I think it's important as part of that holistic approach and positive expectation-based approach. Is there any substantial evidence behind it to really push me to volunteer it? Not at this time. And so that's why it doesn't really form part of the rubric of the approach to either primary or secondary pain in my practice. And I don't know if Dr. Robinson would answer this any differently, but I'll give him the opportunity for sure to do so.
No, I agree completely. And I think in researching it, because I hadn't been asked before involvement at the St. Michael's Hospital Clinic. And so in researching it, the best evidence I found was that it would be very unlikely to harm the person. So in medicine, there's the saying, first, do no harm. And so I do prescribe it when asked, just exactly what you said.
Thank you.
So basically, someone has to approach you and ask for it if you don't practice it.
So the question was, it's generally not prescribed unless asked, low dose naltrexone. Do we have time to get into that briefly?
So low-dose naltrexone is a sort of a drug that works on some of those opioid-type receptors, but in a very particular way, and a very complicated putative mechanism of action that we cannot go into at today's visit. But I think most people ask for it not as a pain reliever, but they ask for it as a neuroprotective agent. They ask for it as a strategy to modify their disease. I've had many patients ask for it, and consequently I've prescribed it many times, but never as a primary pain strategy. No one's ever approached me for pain. And in fact, I've been doing neuropathic pain, not just in MS, but in other neurologic populations for a very long time, if you include all of my years of practice and training, and at no point has that ever found its way onto a list of strategies for analgesia. So I think I'll just leave it at that.
Yeah, so it's not anything against it, but it just doesn't seem to have the proof behind it. A lot of the time when I'm asked about it, it seems to be more to do with energy and fatigue and sort of a sense of well-being. Not a euphoria, I don't mean in that way, but just to have a little more energy.
Okay, and sleep, thank you. Thank you. Okay, now be at the back here with Jennifer, then I'll move my way over to Nancy. Or sorry, not Nancy.
There was a slide actually, and I didn't get it all written down. My right hand doesn't work as well as it used to, but it was just after pace yourself and everything, and it was HTTP and www, and that's all I got. And I wondered if you could show the slide.
That very last slide, that he had a big long, or the one with the pictures?
Blue. I
Yes.
think it was a blue
Yep,
screen.
you'll get that when I mail out the, I'll send that out, actually. I'll send out just that link, and then you'll get it in the recording as well.
Angela, can I state a question that was posed to me at the break, which I thought
Yes.
was excellent? It was a question about referred pain and what is referred pain. And we didn't specifically get into that in this talk, but it is actually part and parcel of that homunculus in a way, and how the body organizes itself neurologically from the very first instances of embryologic life. So how the body is organized, it's organized in a way to conserve energy and for maximum efficiency. And it can only do so much. And in certain representations, areas that kind of started off together are often lumped together in brain representations. So one body part, when the pain signal is getting to the brain, may be perceived at that area where it's actually problematic, but sometimes the brain can get confused and it can mistake it for coming from another place that was very closely aligned with it in embryologic development. And so there are typical referral patterns based on all kinds of representations in sort of skin pathways, in terms of bone ligament structures. And again, I don't want to ramble too long on this, just to state that referred pain has to do with how pain is processed in that matrix.
Thank you. Everyone? Yep, yes, your turn finally. She had a pain question earlier.
Yeah, what I wanted to ask is, I talked to the doctor this morning, and I have terrible time with pain. And I had told him, I kept hearing him say Furanol. And I told him how I have taken Furanol the odd time when the pain's really bad. And he said, keep it up if it's the only thing, which it is. It's the only thing that works. Do you know much about it? Like, could you help me and tell me more about it? Like, I like getting away from the pain, and I'm sure everybody would, but it's a narcotic. So what do you know?
So I can take that one. I do know Furanol. I don't prescribe it. I know it mostly as a headache medication, and it's a combination medication, if people don't know. It has some aspirin, it has some caffeine, it has some barbiturate, and it usually has either a quarter or half grain, that's very old terminology, so you can tell how long it's been around, of codeine. So it's a combination headache medication typically used for muscle contraction type tension headache. But I said I'm a general neurologist. I see a lot more people with headache than I do with MS. It's just the way the numbers go. And I usually see people that are having problems from the medication more than help from the medication. One of those problems is that it is an opiate, as you've identified, so that's not the best strategy. There are other better strategies. Part of it, and I won't go into it in detail here, but part of it has to do with rebound headache. Different medications, if we just take Advil or Tylenol, you would have to take those about 15 days out of the month for your headaches to start getting rebound headache. For Furanol, it's only 6 days out of the month. So it has a strong propensity to give more pain than it actually helps in the headache setting. I'm not sure in your particular setting. One last thing about it is we have to be very careful. So you hear I'm not a fan, and I try to steer people in other directions. But because of the barbiturate, it needs to be stopped very slowly and carefully in a tapering fashion. Barbiturates were some of the very first medications ever. Phenobarbital to treat seizures is a barbiturate, and if it's stopped suddenly, it can trigger a seizure. So that's a word of caution. So we're trying to steer away from it, but not suddenly.
Okay, sorry, what was your question?
It would be tapered over months, I would say.
Thank you. So right in the middle here, Jessica, thank you.
I know we talked a lot about, you talked a lot about dealing with the physical and how to prevent and deal with. What about cognitive issues? How do we deal with that?
So cognitive issues play a role in everything, especially in terms of mood. It depends what you mean by cognitive issues. Can you elaborate on what?
More impaired, I know that it's
In
one of the
relation-
MS, in relation to MS, the shrinking of the brain and some memory loss and
Okay,
processing
so do you mean
and
in
stuff.
general or in relation
general.
to pain?
No, not in relation to pain, sorry.
Okay, because that's where I was trying to get more clarification. So in terms of cognition, exercise is one of the very, very best strategies to maintaining, if not improving, cognitive function. So that is a foundational approach. Second approach is to keep the brain stimulated. Now, there are different ways of keeping the brain stimulated. A lot of people like to do brain training games, and there is some limited evidence that that can be helpful. So things like Lumosity and other online programs. There is some evidence that those are helpful, but they're definitely not helpful to the degree that aerobic exercise is. So those are the foundational components. Then the third component, which is equally important, is to decrease neuronal cell death, so neurotoxicity. How do you do that? Well, you start by, if you have a relapsing remitting disease, being very aggressive about treating that so that as many cells in the brain can stay alive as possible, because as you alluded to, there's a very strong connection between cognitive function and total brain volume. Okay, so having each of those cells stay alive is very important. Having them keep their myelin sheath intact is important as well. So if you're eligible for aggressive treatment with disease-modifying drugs, great. If not, because perhaps you've been deemed ineligible or there's some other reason preventing, then obviously looking to cut out any neurotoxic factors. So you will not want to drink alcohol in excess of the national guidelines for consumption, for example. You won't want to abuse other recreational drugs that may take a hit on cognition. You don't want to do anything that damages the blood vessels that go to the brain. So if you're a smoker, quit smoking immediately, or have a plan, talk to your physician about how to make that a reality in the near future. If you have cholesterol issues, you want to get those under control. So again, you want the caliber of those blood vessels to be as big as is humanly possible so you can get the blood flowing to the brain and in both directions, getting the toxic substances from metabolism out. Energy conservation and pacing, so to be able to make sure that you're doing your cognitive functions at the time of day where you feel the best. And the list goes on and on. So ruling out other conditions that could be either directly affecting cognition or neurotoxic, such as depression. So if there's underlying depression, treating it. That would be the approach.
And that is a whole other topic that we can pursue in the future. There was a question from earlier that I said I would wait to ask Dr. Robinson. It's not related to pain, but the question is there any relation between MS, remission, and pregnancy, albeit temporary?
Yes. No, just
There
kidding.
we go.
So pregnancy is a very interesting condition. There's potentially something foreign, right? The baby is at least half foreign to the pregnant mother. And so the immune system, which we know is very important in multiple sclerosis, is down-regulated so that foreign material, the baby-to-be, is not rejected. And because the immune system is less active, down-regulated, there are fewer relapses during that time. There's a slight bump upward, which is a bad thing, immediately postpartum. So after the baby is delivered, the risk of a relapse is a little bit higher, but not hugely higher than it was before the woman was pregnant. And then after a few months, that goes down to the sort of usual amount, the usual risk for a relapse.
Thank you. I'm going to allow for one more question because I realize it's after time and some of you have rides that you need to get. There's just the questions. Susan, can you just put up your hand so that Jessica can... Over here, Jennifer, sorry. Jessica, this way. I can't remember now anymore who's who.
Hot and cold.
This way. One more question and then we're going to say thank you.
Well, it's not a question, but a comment.
Okay.
So I really love the fact that you brought up the comment about gratitude because I read a wonderful book a couple of years ago called The Magic by Rhonda Byrne. And she, quotes that every step of the way in the book. Every day you write down 10 things that you're grateful for. And I went through that entire process. I'm telling you, that was life-altering, right? So thank you so much for bringing that up because that had a huge impact on me. So thank you.
Thank you, Susan. That was a lovely way to end the session. So we do thank Dr. Bruno and Dr. Robinson. We appreciate you both being here and taking time from your busy family schedule as well. I personally appreciate, and I've already said thank you to the AV team, of course, all the speakers that we had today, for each of you for being here. But I want to especially thank the MS Society staff and volunteers that you don't maybe know them around the room right now, but they were all in for meetings yesterday, spent a full day of training and sharing of information, and I greatly appreciate each of what they do, and I especially hope that you can connect with your local representative of the MS Society, if not here, back home, but I thank them for the time that they spent here today, not only to learn, but also to help behind the scenes, and have a safe trip home.